Welcome to Unit 12, Adverse Complications of Blood Transfusions. Transfusion of blood and blood components is usually a safe and effective way to correct hematologic deficits. Complications during transfusions may occur, and these are called transfusion reactions, and they include a broad range of events and problems. Some reactions are preventable, some are not. The risk of transfusion must always be weighed against the benefits. When we're talking about transfusion reactions, there's two categories or classifications. The acute or immediate reactions that occur within the start time and during the transfusion itself, and then delayed reactions, which may occur hours, days, or even weeks after the transfusion. In the clinical evaluation of a transfusion reaction, the time between the reaction occurring and the investigation must be as short as possible. There's a two-pronged evaluation, the clinical evaluation of patient that's done by the nursing staff, and the laboratory investigation and testing, which is done by the clinical laboratory staff. The responsibility of initiation of the transfusion reaction rests with the transfusionist. I would love it if during your rotation you could see an actual transfusion get started. The procedure, the blood is picked up from the transfusion service. It's taken to the patient's room where at the bedside 2 licensed personnel check the forms against the blood product label and the patient armband. So the blood product will have a label on it that includes the patient's name and medical records number. They take the pre-transfusion vital signs. This is our baseline. What if the person is already running a temperature of 101? What if their blood pressure is either high or low? So again, we get this baseline of vital signs to compare with later on. The transfusion is started, and if possible, the nurse should stay with the patients for the first 15 minutes. It has been documented that the most serious and deadly reactions occur within the first 15 minutes of transfusion. After 15 minutes, and they should set a timer and come back to the room, they retake the vital signs to ensure there's no change, that the patient isn't immediately reacting to this blood transfusion. If the vital signs are unchanged, continue the transfusion, which must be completed within 4 hours. I want you to memorize that, within 4 hours. It's best to infuse the blood as quickly as the patient will tolerate it. Shorter times are preferred, and usually 2 hours is the usual time frame for transfusing blood and blood components. Check on the patient periodically to make sure they're okay, that they're not they're feeling hot, or their urine's turning red, or anything like that. Upon completion of the transfusion, take the vital signs again. And as part of an audit trail for transfusions, these should be looked up on every patient's chart that receives a transfusion. So again, the blood is picked up using proper identification. The licensed personnel check the product label against the patient armband. Then take the pre-transfusion vital signs, start the transfusion. After 15 minutes, retake the vital signs. If unchanged, continue. Transfuse that blood product as fast as the patient can tolerate it, and then take the vital signs upon completion of transfusion. So what should the nursing personnel watch for during a transfusion? Fever and chills are the most common types of reactions. Pain or burning at the infusion site. This is usually indicative of an ABO incompatibility, and those red cells that are incompatible are being destroyed as soon as they enter the circulatory system. Abdominal, chest, flank, or back pain, hyper or hypotension, nausea, vomiting. Some skin manifestations which may occur are urticaria, rash, flushing, pruritus, and localized edema. Respiratory distress would include wheezing, coughing, and dyspnea, which is shortness of breath. Jaundice or hemoglobinuria, if there's massive amounts of red cells being destroyed, the hemoglobin then is visible in the plasma or serum on the sample that's drawn, and because the amount is so large, they can't tolerate taking care of that amount, so they may turn yellow, which is jaundice. Abnormal bleeding or generalized bleeding, disseminated intravascular coagulation. Oliguria, which is a decrease in urine production. Anuria is no urine production. Hemoglobin is very, very toxic to the kidneys, so it's so important to recognize an acute hemolytic transfusion reaction, because intervention can help save the kidneys, and the patient may eventually go into shock. Let's talk about patient-focused steps first. A nurse calls you and this is, my patient's having this and this and this type of symptoms. What you're going to tell them is stop the transfusion immediately. And the reason you're going to do this is to limit the amount of blood infused. If this is truly an acute hemolytic transfusion reaction, the more blood they get, the more serious the reaction will be, and potentially the patient may die. And when the patient has a transfusion reaction, notify a responsible physician. The nurse should know to keep the IV line open with infusion of normal saline. If this is an acute hemolytic transfusion reaction, they're going to have to administer medications quickly, and the best way to do that is through an IV. At the patient's bedside, the nurse should perform clerical recheck between the patient and the component. She or he should check all labels, all forms, and the patient identification to determine if the patient received the intended component. If the information does not match, notify the patient's physician immediately. Of course, you should have notified them from the beginning, but this takes on a sense of higher urgency. Make sure that the patient whose name is on the blood product is not being transfused with the product intended for this recipient. Perhaps the nurses checked it in the hallway and they end up taking the wrong product to the wrong room, and 2 patients are now at risk. So again, I told you the story. The nurses must have checked it in the hallway, the identification, because they went in and transfused the wrong patient. Fortunately, the patient and the blood product were ABO compatible, and when the cross-match was done, it was also compatible. But this could have had serious consequences if the patient was ABO incompatible with that donor. The component-focused steps is contact the transfusion service immediately. Return the discontinued bag of blood, the administration set without the IV needle. Of course, now they have permanent covering of IV needles, and if that's the case, that's okay that they send that down. And the attached IV solutions and all the related forms and labels stat. The reason we need to look at the transfusion solutions, the IV solutions, is what if they were giving this blood with D5W, and that contains water, and water in close proximity to donor blood will hemolyze it. So we need to immediately check and see what potential causes of this reaction are, and it could be that IV fluid. Send the required blood samples, carefully drawn to avoid mechanical hemolysis, to the transfusion service stat. And I can't emphasize this enough. Everything needs to be stat, 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 because the patient's life could be in danger. Send other blood samples for evaluation of acute hemolysis as directed by the transfusion service director or the patient's physician. Laboratory investigation handles this as a stat each and every time. One of my colleagues, it would start on evenings, late in the evening, the transfusion reaction was called. Night shift was really, really busy and they didn't deal with it. Day shift dealt with it, and unfortunately it was a hemolytic transfusion reaction, and it was due to anti-JKA. This is rare for anti-JKA to cause hemolysis, but that is one of the most common antibodies that will cause an acute hemolytic transfusion reaction. And the results were consistent with a hemolytic transfusion reaction. So don't put this off. It only takes a few minutes to do the workup. Clerical check identification of the patient blood sample, the labels, the paperwork, and the donor blood. Yes, I know the nursing service already did this. You're going to do it again. Repeat ABO testing on the post-transfusion sample and do a visual check comparing the patient's pre-transfusion and post-transfusion specimens for the color of the serum or plasma. And if it is hemolyzed, then you immediately call for a recollect. That happened to me one time. I spun it down and oh my gosh, it was totally hemolyzed. So I'm really ramping up doing my testing, but I requested another sample. And sure enough, it had been a traumatic draw. The sample that was the second one submitted was normal. Perform a DAT on the post-transfusion specimen. So what I do, the sample gets to the blood bank, I label a tube for my cell suspension, immediately transfer a little bit of blood, then I put the sample into the centrifuge to spin it down. While that's spinning down, I'm doing my DAT. I make my cell suspension, I put the drops in the required number of tubes, wash 3 times, add Coombs. By the time the sample's through centrifuging, I'm pretty much done with my DAT. And I'm also doing my ABO. So from beginning to end, a transfusion reaction workup, if it's all good, should not take more than 15 minutes. If everything is negative or normal, nothing further needs to be done. So again, you do the clerical check, you spin the sample down, check for hemolysis. Prior to spinning it down, get your red cells, and at least you can do the forward type and the DAT. Once the sample finishes spinning, then you can perform the reverse. And again, you want to do this as quickly as possible because I said the one time that you ignore it, the patient. So additional laboratory tests for acute hemolytic transfusion reactions. If the DAT is positive or hemolysis is present in the post-transfusion sample, additional testing must be performed. And basically, you're going to repeat the ABO D-type and cross-match fully on both the pre-transfusion and the post-transfusion at the same time. So repeat ABO D-type, repeat antibody screen, repeat the cross-match through Coombs. Normally we don't do through Coombs if the antibody screen is negative. This time you will. If tests on the pre-transfusion sample do not match the post-transfusion sample, notify the blood bank supervisor or medical director and the patient's physician. Again, for hemolysis, request a redraw stat to verify in vivo versus in vitro hemolysis has occurred. What is the investigation for non-immune hemolysis? This is a non-antigen antibody reaction. Consider bacterial contamination of the donor unit. If the cells or plasma have a brownish or purple discoloration, if there are clots or abnormal masses in the liquid blood, or the segments closest to the primary bag appear hemolyzed, and if you don't know how to do this, you need to get assistance from a more senior tech. The plasma is opaque or muddy. This has to do more with plasma products, especially platelets. If there's a peculiar odor, the bacteria, if it's a bacterial contaminated unit, they produce gases. These gases can leach out of the bag. And review the visual assessment of blood components handout that I provided so you can get a general idea of what normal versus abnormal looks like. If any of these characteristics are noted, take the bag to the microbiology department and they need to set up cultures to be done at 4 degrees, 20 to 24 degrees, and 35 to 37 degrees. This way we'll capture any type of bacteria that grows at any temperature. Because if the bacteria survived in the refrigerator, that's a good sign that it may grow at 4 degrees centigrade. Once those cultures are set up, perform a gram stain on the unit, and if bacteria are present, be sure and let the physician know. Examine the supernatant plasma from the donor blood container for the presence of free hemoglobin. This may be hard to do because if you don't have a centrifuge big enough to centrifuge the donor units, otherwise you let it sit upright. Examine the blood remaining in the administration tubing for the presence of free hemoglobin. As I said before, incompatible IV solutions can hemolyze blood. Consider the possibility that the patient or donor has an intrinsic red cell defect such as G6PD deficiency or paroxysmal nocturnal hemoglobinuria. Consider the possibility of mechanical hemolysis. In the OR, when they're doing heart surgery, they do bypass, and the blood is bypassed into a machine with rollers to assist it getting through, which oxygenates the blood for the patient before returning to it. So maybe the tubing has a crimp, maybe the rollers are set too tight. Consider osmotic hemolysis due to inadvertent entry into the circulation of hypotonic fluids, and this is hypotonic IV fluids. Although they do, when they're doing a transurethral resection of the prostate, they irrigate with water, and if there are vessels that are open, the water may inadvertently enter their circulatory system. Very, very rare. Once hemolysis is proven, you want to examine the post-transfusion urine specimens for the presence of free hemoglobin. Once hemoglobin exceeds the reabsorption capacity of the kidneys, it will be found in the urine. Test post-transfusion serum samples for unconjugated bilirubin, carefully recording the timing of sample collection. The peak levels occur about 5 to 7 hours after transfusion and disappear within 24 hours. Measure the serum haptoglobin in the pre- and post-transfusion specimens. Haptoglobin is a protein that binds hemoglobin, so in the pre-sample you would expect to have a normal amount of haptoglobin unless there's a car wreck or something else involved. But for normal patients, it should be it should have the normal amount. Post-transfusion, if there is hemolysis going on, you will see a dramatic decrease. And this is going from most common testing and expected results to the least common expected results. So let's say that hemolysis continues to be suspected, but the tests are uninformative. They don't give us an answer. What you would want to do is perform antibody detection tests with more sensitive methods. Let's say you're using LIST, then maybe you want to use PEG, or do things that will enhance or increase the sensitivity of your test system, increase the serum to cell ratio, increase the incubation time. Perform DAT and IAT daily or more frequently. Measure the H&H at frequent intervals to document the rise or decrease. After transfusion, the patient didn't get much blood, we hope. So the pre-H&H and the post-H&H should be the same or maybe a little bit higher on the post-H&H depending upon how much blood they get. If there's a decrease, then something's going on. And we're really going out in the woods for this. You want to type the cells of the recipient and the donor to find antigens that are present on the donor but absent on the recipient. Because maybe something's going on that for some reason we're not detecting the antibody, and but there is some type of immune response going on. Now, when you're typing the recipient, you must use the pre-transfusion sample, because otherwise, if you test the post, it's donor blood and patient blood. If hemoglobinopathy is present, perform hemoglobin electrophoresis to verify the presence of normal hemoglobin. So let's say the patient has hemoglobin C, or if they have hemoglobin S, then you would not expect to find a normal hemoglobin A in the patient sample. So again, these are really going out in left field. I've not ever had to do any of these procedures, but this again is if hemolysis is strongly suspected, but the tests that you've done do not give you the right information. The most feared type of reaction is the acute hemolytic transfusion reaction. This is triggered by an antigen-antibody reaction which activates complement, coagulation systems, and the endocrine response. Catastrophic clinical events may occur. The patient may go into shock. The patient may go into disseminated intravascular coagulation, which, remember your coagulation, is where you're trying to clot, but you can't. And in the process, you're using up all your coagulation factors, so you will continue to massively bleed. Acute renal failure is one of the biggest concerns as well. Life-threatening AHTRs are almost always due to ABO mismatch because you have those naturally occurring antibodies that are built against those ABO antigens you do not possess. So you have IgM and IgG, and as soon as that blood's going into the circulatory system, it's being attacked. And IgM is very, very good at activating complement, so that will result in hemolysis. Other blood group incompatibilities may cause hemolysis, usually not as severe as ABO. The other one that you need to think of is the anti-JKA. So how is diagnosis of the acute hemolytic transfusion reaction made? The most common initial sign is fever, and that's why the vital signs are so important, that they're taken prior to starting the transfusion and after the first 15 minutes, because usually most patients will have the reaction within the first 15 minutes of a transfusion, but they may also have it towards the end. That is why after the transfusion is completed, the vital signs are taken again. Reaction may occur with as little as 10 to 15 mLs of incompatible blood. The onset of symptoms may be mild. There's a burning sensation at the IV site. The patient may experience vague uneasiness. They'll tell you, I think I'm going to die, and they do. Abdominal, chest, flank, or back pain. The first sign the patient may observe is red or dark urine with or without back pain. So they need to go to the restroom and they pee in the toilet and they notice it's red. They should immediately contact the nurse because this is bad. And the back pain indicates that the kidneys are being overwhelmed with hemoglobin. The severity of the transfusion reaction is directly related to the amount of blood transfused. If the patient is anesthetized, bleeding at the surgical site may occur, hypotension, or the presence of hemoglobinuria. Usually when a patient undergoes general anesthesia, they will catheterize them. So somebody should be kind of looking at the bag every now and then because the urine may start being red. And in addition to bleeding at the surgical site, sometimes if this is an ABO incompatibility, it could lead to disseminated intravascular coagulation where wherever they have a needle, for example at the IV site or other cuts, they will start bleeding. Again, stop the transfusion immediately and keep the IV line open. Can we prevent all acute hemolytic transfusion reactions? Absolutely not. It's impossible. Hemolysis may occur even if the cross-match is compatible. Can we prevent all acute hemolytic transfusion reactions? Absolutely not. It's impossible. Hemolysis may occur even if the cross-match is compatible due to an anamnestic response. The patient was transfused years ago, made an antibody. It's fallen below the detectability of our screening process. You didn't know they had the antibody. The patient's transfused with cross-match compatible blood, and that anamnestic response kicks in, rapid increase in antibody, and a large number of transfused cells will result in acute hemolysis. Other errors that may cause AHTRs is human error. The wrong sample from the wrong patient. If you recall, I told you the story where a cross-match was ordered and I went and drew the patient, and the patient was AB pos. We didn't have AB pos. I had to order it. Another cross-match came in for the patient in the other bed, and that my colleague went and drew them and that patient too was an AB pause, and I had to order the blood and let the floor know. And I was very early in the field. The doctor comes in and says, no, there's no way both these patients in this same room are AB positive. And so he made us recollect both patients, and sure enough, my colleague had drawn the wrong patient. One of the patients had left the room, and he assumed the one that was in the bed was the patient he was supposed to draw. So always, always, always check identity of your patient. The tech mixed up the samples, and you need to get your system down where working with multiple samples is a must do. If you work on sample 1 and then sample 2 and sample 3, it'd take you all day long, and patients would start bleeding out. And I'm being facetious about that, but still, you need to work at least on 4 samples at a time. And what I do is I spin my sample down, I label my serum and red cell tube, and I look at the label, make sure that label matches of my handwritten tube, and put the samples in the proper tubes and process them and whatever. And I do that for all 4 samples. Then, after I've washed my cells and this, that, and the other, I'm going to start dropping patient serum and cells. I double check again that sample label matches the original sample label in the back of my rack. Blood transfused to the wrong patient. Oh my goodness. There was a case that there were 2 patients in the room, and one patient really, really, really wanted to be near the window. And so the other patient obliged, said, oh, sure, I don't care. I'm just reading and whatnot. So a transfusion had been ordered on the original patient near the window. Well, the nurse came in, did not check identification, hooked up the patient to this blood, and the patient died. And this was big news in the blood bank world, and I can't remember, I don't know, 5-10 years ago. So this patient lost their life because they wanted to be by the window. And their healthcare provider, I don't care how busy you are, I'm busy too. They failed to check the identity. So the bottom line is standard operating procedures must be followed by everyone. The nursing staff, the phlebotomy staff, the laboratory staff. If a fatality does occur, it must be reported to the FDA within 24 hours. This is the end of Unit 12, Part 1.